Thank you so much, Jorge. What a beautiful introduction. I'm so glad to be here with you all today. Um, and yeah, we're going to talk all things trauma and teaching emotion regulation and affect regulation skills for people experiencing trauma. Let me share my slides with you now. So yes, from survival to resilience. So that's what I'm going to be talking about today, and specifically a lot about teaching emotion regulation skills to refugees and to anybody we're working with where trauma is part of the picture. I'd like to acknowledge as well the traditional custodians of where I sit today. I come to you from the New South Wales Central Coast. The traditional owners are the Darkinjung people. And Jorge's done a great job of introducing me, so I don't need to focus any more on that. And yeah, that's just a brief overview for you of what I'm going to be covering today. Now, first of all, I just want to acknowledge the picture of trauma with refugees. Now, I'm not going to go into any detail here because I'm speaking to experts in this area already, but I think it's important just to frame what we're going to speak about by understanding the different layers and the multi-layers of trauma that a lot of refugees have experienced from their countries of origin, what we might call pre-flight times, to the process of seeking asylum, migration, the process of migrating and settling, and then all the structural issues that they face in this process that can go on for quite a long time. And so when we look at the refugee experience, this is a very complex trauma experience. This is not just one trauma incident that they've experienced. There is, multifactorial, multi-levels of trauma here. And I'm going to talk today a little bit about complex trauma as opposed to PTSD and what that might look like. So we know that the impact on refugees of these, multi-traumas is significant, and things like nervous system dysregulation is very common. Sometimes physical and somatic symptoms, post-traumatic stress disorder. So the studies indicate, somewhere around 30% of refugees have signs of PTSD when they arrive. I would suggest that if we expand our definition of trauma, the numbers would be much higher than that. I know I've certainly worked with people who are profoundly impacted by trauma but may not actually meet the criteria for PTSD, but it's still a very relevant area that we need to work on with them. We often see rates of obviously depression, anxiety, other serious mental health issues that emerge, substance abuse, interpersonal difficulties, dissociation is very common with highly traumatized people, and self-injury and unfortunately suicidal behavior also very common within this population. So I want to sort of explore now, the experience of trauma for a lot of people is there becomes a fear of feeling as part of the traumatic experience. And so, when we talk to people that have experienced trauma, they'll often start to tell us about their beliefs about their emotions because of their trauma. They'll start to say things like, I feel like my emotions are too much, they're too big, they're too intense, or my emotions are dangerous, they can harm me, or things like, I can't handle being triggered, or they start to talk about, I think there's something wrong with me because I can't control my emotions, I can't control my triggers, I can't cope. And we start to see the eroding of self-belief, the longer that trauma goes on, sort of, unmanaged, that people really start to think that they're broken, that their brains are broken, that their bodies, their nervous systems are broken. And they really start to live in a world where they need to try and avoid intense emotion, memories, flashbacks pretty intensely. And so the role of avoidance is really important in understanding emotion regulation and affect regulation. So avoidance behaviors are very understandable in the context of trauma. They come up because people are overwhelmed and scared of those feelings. And avoidance behaviors do make things better in the short term. They do serve a purpose. and they make people feel better. They give relief. However, they make things a lot worse down the track. And common avoidance behaviors are things, again, like drug and alcohol abuse. Sometimes aggression or violence can be a really effective avoidance mechanism of sort of releasing pressure or emotion. Isolation is a big one, very common. Disordered eating, and again, self-harm and suicidal behaviors. These behaviors all have negative consequences, but there's a bigger problem, which is that when people get into a chronic pattern of using these behaviors for relief, they actually become less and less tolerant to distress in the long term. And I'm going to talk a little bit about that. This is sort of a visual of what I'm describing here. And as you can see in the top corner here, if we start with intense emotions. So let's say somebody experiences, trauma, they're experiencing very intense emotions that feel outside of their capacity to regulate. They go into overwhelm. What happens then is that they become very fearful of those emotions and those potential triggers. They then start to look at avoidance behaviors, and their clever brain finds very effective ways to get rid of distress quickly or to avoid triggers. And this is where we see problem behaviors and avoidance emerge. Then what happens is something really important to understand. Emotions want to be felt, right? They're biologically hardwired so that they're supposed to serve a purpose for us. Even pain has a purpose at alerting us sometimes to where change is needed or something that needs our attention. And so when we chronically avoid emotions or try to dampen them down, they actually come back more intense. So sometimes called the pain paradox, which you may have heard me talk about. And so the more I push away unpleasant emotions, the more intense they'll get. Sometimes that manifests in somatic symptoms, dissociation, things like that are involuntary. But there's an intensifying of distress because of that chronic avoidance. And then you can see how we go around the circle. So now distress has gotten more intense, emotions have got more intense, and I feel overwhelmed. It's beyond my capacity to regulate. I'm now more scared of my emotions. I need to do more avoiding, and around and around. And this sort of turns into a spiral where just stress is going up. And people have to do more and more to avoid those emotions. And we can see an escalation here of avoidance behaviors where more serious and life-threatening behaviors like suicide may start to become pretty predominant. So this cycle really shows us the problem with unacknowledged emotion. And the problem with chronic avoidance. Now, no judgment, this is people doing the best they can. This is actually healthy brains just trying to survive. The problem is that we're not allowing space for those essential hardwired emotions to be recognized, and they will escalate if they're not recognized. So this leads us to what I call the distress versus capacity model. I have to give credit here to John Briere. If you haven't read his stuff, highly recommended. A really great trauma author, researcher, and clinician over at the Keck School of Medicine. And this model, I think, just really beautifully illustrates for us as helping professionals how to understand what's happening and where we can intervene. So on one side here, we have level of emotional pain or distress. So this is how much pain or distress we're carrying, how much trauma content, how much yucky, unpleasant stuff we're carrying. And then on the other side, we have the level of distress tolerance we have. How much distress and emotional pain can I tolerate before I hit overwhelm? What is my capacity to sit with distress without becoming overwhelmed? So we have these two factors, and how they interact is really, really important to understand. So for this person, their level of distress is pretty low. They say they have some, they're human, they're awake. So they have some distress, but their level of distress tolerance, their capacity to manage distress is higher than their distress. This person's doing well, right? This person is going through life and managing okay. When this changes, that's when we start to see crisis and overwhelm. So for this person, their level of emotional pain is quite high. You can see that. And their level of distress tolerance, their capacity to manage distress is lower. This is what crisis and overwhelm looks like, right? Whenever pain is higher than the capacity to manage pain, this is when people are going to be struggling. This looks the same as well. Now, this person has very high levels of pain, probably lots of multi-traumas there in the background. They have a pretty high level of distress tolerance, but the pain is higher. So this is still going to look like overwhelm, even though they've got some good distress tolerance. And it looks exactly the same as this clinically in front of us. This person's level of pain is, objectively maybe not that high, but their distress tolerance level is very low. And that can happen for a bunch of reasons, but whenever that second bit is lower, we're going to see overwhelm. So we have two options here, okay? We could try and lower the level of pain. Okay. Now, traditionally, we would do that by maybe traditional trauma therapy, where we'd have the person talk about the trauma a lot, things like that, long-term psychotherapy. The problem with this option, number one, takes a really long time, right? Years. Number two, it can make people worse if they don't have enough distress tolerance skills on board. So if I put somebody into traditional trauma therapy, talking about their trauma for an hour every week, and they don't have great skills to manage what that's going to bring up, I'm going to make them worse. So we need to be really aware of that. So reducing pain is difficult, but it also has risks at trying to do that. The other thing we can do, and I'm going to suggest to you is a much better place to start, is we can increase their level of distress tolerance. We can increase their capacity to sit with distress. And then even if I do nothing with this pain, we don't reduce it one iota, guess what? They're going to be feeling a lot better. They're going to be functioning pretty well. They're not going to be in overwhelm. So this is what I'm going to talk to you about today, about increasing the capacity to manage distress. In an ideal world, we actually do both if we have the time. However, sometimes we don't. Sometimes we just do this one, or sometimes clients only want to do this one. And that's totally fine as well. Not everybody wants to do in-depth trauma therapy, and not everybody needs to. Let's talk about the brain and trauma. Very important part. I think psychoeducation for our clients around brain chemistry is essential, but also it allows us to address this in order of when we're going to introduce skills. So we've got these two main parts of our brain, which I'm sure you all know about. Our primitive brain, which has that beautiful amygdala, the threat detector, tells us when the lions are running at us or when there's danger. And then we have our prefrontal cortex, right? The advanced brain, where all our good emotion regulation skills and rational thinking live. Interesting research coming out now actually about frontal lobe, and it looks like people with ADHD, perhaps frontal lobe growth takes a little longer than for neurotypical people. For neurotypical people, we think the frontal lobe is maybe developed sometime between 25 and 28. For people with ADHD, it's looking like the frontal lobe may not fully develop until 30 or even mid-30s. So just interesting to note there. Now, when somebody is triggered, right, when their amygdala is triggered, they get that activation in their primitive brain. And so this is happening for our trauma clients frequently. And so they're getting activation in the amygdala. But what happens is when the amygdala fires, the frontal lobe goes offline, right? It shuts down. Because if lions are running at me, I don't need to pause and weigh up the data. That would be a bad idea, right? I just need to act first and ask questions later. The problem here, though, is that when the frontal lobe goes offline, there goes all of the great cognitive skills and rational thinking that that client might have when they're not triggered. So when a brain goes offline, we have no access to those cognitive skills, no ability to reason through things. sometimes intense physical symptoms that become really dominant in people's awareness. And then people start to feel frustrated. Why can't I think straight? Why can't I get it together? Why can't I use all those skills that I read about the other day, right? And for trauma survivors, particularly complex trauma survivors, they're going offline a lot of the time. Now, to differentiate here, just briefly for you, PTSD, post-traumatic stress disorder, being a DSM diagnosis. Complex trauma, when I use that term, I'm talking here about people who may or may not meet the criteria for PTSD, but have other issues related to trauma, such as, negative self-image, large amounts of shame, interpersonal difficulties, attachment difficulties. Often people who've experienced multi-traumas and or interpersonal traumas. So they've been hurt by people. There's an added layer of complexity that we acknowledge in those folks. And so if you imagine that your client who's experienced interpersonal trauma, they've been hurt by people, people are their trigger, right? So every time they're interacting with people, including you, they are going potentially offline. So this is a lot of time they might be spending offline. So we need to know that cognitive therapy is not going to work with a brain that's offline. It has benefits at other times, but it's not going to be the answer when my client is having to go offline a lot. And we also need to recognize that clients are doing their best, that this isn't willfulness or a lack of effort or anything like that. This is literally a healthy brain doing what it's designed to do. And I like to frame it like that for people so that we challenge this idea that their brain is broken or that they're not coping somehow. It's the opposite. Their brain is so clever that it would rather overreact and be wrong than the other way around. But the longer the client goes without understanding what's happening in their brain, the more distressed they're going to get, and the more shame is actually going to start to set in. So we have to deal with this brain chemistry issue first. And I would be doing this in the first or second interaction that I have a client. I'd be introducing these ideas. So let's talk skills. The first set of skills that I think every client with trauma needs are tip skills. So these are from dialectical behavioral therapy. All the skills I'm going to introduce you to today are from that. And tip skills are some of the fastest ways we know to deactivate the amygdala, or at least take the edge off the amygdala and get that frontal lobe back online. And there's 4 of these skills. I'm not going to go through them in a lot of detail. I'm going to give you a brief overview, but certainly if you don't have these skills in your toolkit, definitely look them up and get them. The first skill is where we encourage clients to put their face into a sink of cold water and hold their breath and bend over. This drops heart rates very quickly, triggers something called the dive reflex that all mammals have. It's just a little nervous system trick. This is a very fast and powerful way to get that amygdala to settle down and get that frontal lobe back on. Then the client can access all of their higher level skills, right? Like challenging thoughts and checking the facts and all that stuff. But we have to deal with the brain chemistry first, otherwise we're setting them up to fail. We've got intense exercise in there. So we know that 20 minutes of intense exercise, about a 7 out of 10 on the exertion scale, will help deactivate the amygdala. We have a paced breathing exercise, which is basically long exhales that are twice as long as inhales. Very effective for settling down the heart rate. And what we're really doing here is that we're trying to deactivate the sympathetic nervous system, right? We're trying to hit the big relaxation button there, if we can find it, and get that to settle down and get that frontal lobe back online. And then we have a paired muscle relaxation exercise, which is tensing muscles on both sides of the body for 20 seconds, releasing and repeating. So very simple practical skills that we should all have in our toolkits. Clients need to know these session 1 or 2, in my opinion. Once we've taught those skills, then we can go into some more detailed skills. So in DBT, we have something called accepts, which is basically skillful distraction. So it's a way that we teach clients to use distraction skillfully. We don't want clients to distract all the time. That could turn into an avoidance, right? But when they're in overwhelm or they're approaching overwhelm, distraction can be really, really helpful at writing out the intensity of that. We also want to teach some self-soothing. This is very hard for people. And, particularly when people are carrying shame, self-soothing is like the opposite of that. But still very important to teach people what to do. It does take a while. We want them to use their senses to do soothing things. So, soothing smells, soothing sounds, soothing tastes, soothing, tactile sensations, using our senses to try and help that nervous system. Self-soothing is not going to work when they are 10 out of 10 overwhelmed, but it will certainly help when they're either distress is building or on the other way down of that wave. We have a set of skills called improve skills. So these are just a bunch of different ideas that you can also add to your toolkit to give to your clients. It stands for imagery, so guided imagery exercises, meaning making, where we talk about, sometimes the meaning associated with struggle and sometimes a silver lining to struggle. Prayer, which can mean lots of different things to different people, but often really helpful to explore with clients as a helpful tool. Relaxation exercises, doing one thing in the moment, which is a mindfulness type practice. Vacation, which is a time limited time out from life, allowing people to kind of take breaks when they want to. And encouragement, which is looking at self-talk, right? And trying to challenge the critical self-talk that might be going on. Pros and cons is another skill that's really helpful to have in your toolkit. This skill is really about dealing with ambivalence, about engaging in certain things or help seeking or changing behaviors. Often people can be ambivalent. Part of them wants to change and part of them doesn't, especially if I've got a really effective avoidance behavior going on. Part of me might not want to let that go. And pros and cons, the way that we do it in DBT can be very helpful at people seeing the trade-off between, pushing for change versus not. And then mindfulness. Now, mindfulness is almost impossible to do when we are in overwhelm, but incredibly, incredibly helpful as part of just a daily routine or several times a week. Really great research around less activation in the amygdala for people that practice mindfulness on a regular basis. A lot of the studies are sort of around the 8-week mark and being able to see significant reduction in activation in the amygdala and even gray matter growth in the frontal lobe, which is pretty amazing after just 8 weeks of regular practice. The key with mindfulness is people finding what they like. So not everybody wants to sit and breathe. Not everybody wants to sit on a cushion. There are so many different ways to do mindfulness that you can explore with them and finding what works for them. If we have the time with clients, if we're going to work with them for a period of time, I'd also recommend getting into some deeper emotion regulation concepts. I'm starting to discuss purpose of emotions. So educating around why do we have pain? Why do we have fear? Why do we have sadness, right? And clients starting to understand that these are not bad emotions and we actually can't get rid of them, but we wouldn't want to even if we could, right? We want to befriend them. And understanding that means that people are going to avoid less. We might want to also challenge myths about emotions. Some of those things I touched on earlier about my emotions are dangerous or my emotions are too much. Really looking at challenging that stuff. Emotions can't do anything to us without our permission, right? They can't make me do anything without my agreement. The most emotions can do is make me feel uncomfortable in my body for a temporary period of time. All the other problem behaviors are me trying to get away from emotion. And that's a very important distinction. It's not emotions that cause the problem, it's our attempts to avoid the emotions. So we can do lots of great work around that to reduce avoidance and for people to be less scared about feeling. We definitely want to teach emotional literacy. We know people that can name their emotions can regulate their emotions much better. So just modeling and teaching, how do we name an emotion? How do we know what's showing up? Starting to practice that. We have a skill called opposite action for emotions that we teach in DBT. And this is for times when an emotion shows up, but it's not super helpful to act on, and it may not fit the facts of the situation. Let's say, for example, I'm in the supermarket and I suddenly feel overwhelmed with fear, right? If I act on the fear, I'll just ditch my trolley and scurry on home without what I need, right? Not super helpful. And if I check the facts in that environment, hopefully I'm not in danger. If I am, then I should leave, but let's assume I'm not in danger. So in that situation, I'm going to try and practice an opposite action, which is I'm going to check the facts and then I'm going to do the opposite of the urge. So rather than avoiding, I'm actually going to stay in or even approach the situation that is safe but feels scary. And the more that I do that, the less power that fear has over me. And we're sort of taking fear from this big, scary monster down to its right size, which is it comes and goes, but it doesn't feel bigger than us and in control. So a really great skill to teach. Validation skills, really, really helpful, particularly when dealing with shame. So this is teaching people how to find the nuggets of truth in their experience and to validate that. Even if they have done things that they genuinely feel ashamed about or regret, we can still offer validation around that. And I notice with my clients, I start out as the validating voice, but what I want to happen is I want them to start to internalize that validation for themselves. So that takes time, but if you have the time, really powerful skills. And then radical acceptance skills. Radical acceptance skills are really important when life is not the way that we would like it to be, and we can't change it right away. And this certainly fits for a lot of the people that we're working with, certainly people from refugee backgrounds. Life is probably, not the ideal that they had hoped for, and yet, they can only change certain parts of it. And radical acceptance is about reducing the suffering associated with trying to change what we can't change. It's purely a tool to reduce our own suffering and personal struggle. It doesn't mean we're anti-change. In some ways, it actually makes change more likely to happen if I'm able to let go of some of that struggle and put my energy elsewhere. So some essential factors in trauma work. First of all, those of us who are working with people with trauma, we need to have knowledge of these skills. Some of these skills that I've just run through, we need to have our own really, really good toolkit in order to teach it. So we're taking this toolkit and we're handing it over to clients so that they have it as well. And so if some of the skills I've gone through today are new to you, I really encourage you to find some good training and add those to your toolkit. It's going to be really helpful for you and your clients. The second thing that's really essential is relationship. All the research into therapy work tells us that the quality of the therapeutic relationship is the main predictor of outcomes. And so, even though we're using all different models and all different skills, relationship comes first. So how do we build and nurture a safe relationship? Remembering that people with trauma are triggered by people. They're triggered by us, right? So we may need to work harder and longer to build that safety. And we want to really be validating. I want to have unconditional positive regard for my clients, even if they're engaging in really difficult behaviors. I want to really understand the why, and I want to reflect that acceptance to create that safety. Again, people with trauma histories can be very, very sensitive to perceived rejection. And so we need to be careful about that and be more warm when we're working with trauma than maybe some other conditions. Oh, there we go. This is my effective therapy pyramid. So this is just how I visualize, particularly if I get stuck with a client. At the bottom here is relationship. Again, we've got to build that first. Once we've got a good, safe relationship, then I'm going to teach skills. Nothing can happen until that client has some tools in their toolkit, and then comes change last, right? If I get stuck and maybe I'm trying to teach skills and the client's not really into it, go back to relationship, right? Or if something happens, some rupture and a repair is needed, go back to relationship. So when in doubt, go back to the base and work on that, and then work your way up through. And finally, some other points. So I really think an anti-oppressive approach is really important when we're working with trauma, particularly refugee trauma. Power imbalances are very, very triggering for these clients. We need to think about even things like, how do we dress? How is our office set up? What is our process of intake? Am I sitting there with a clipboard or a computer in front of me that maybe I don't need to do? Right? Just trying to mitigate some of those power differentials. Now, we're never going to be totally equal in power, right? We're still the professional and they're still the client, but just trying to minimize any extra damage that may be done there. Clinical supervision, right? When we're working with trauma, we need really great supervision. We hear things day in and day out that other people would never hear. And we forget, right? We forget that this is not normal to hear all of this stuff. But more than that, I think that, sometimes if you find that maybe your supervisor is your direct line manager or your team leader, and they might be great, but seeking external supervision can have huge benefits as well. Finding someone who really specializes in the areas that you love to work in, and having that great working relationship. I've always done that through my career, and I've never regretted spending the money on some really good external supervision in addition to internal. And then finally, be adaptable, right? So yeah, we want to follow evidence-based practice, and we want to have good reasons for what we're doing, but we need to be flexible. People are different. If something's not working, take a step back, consult with your supervisor, have a little rethink, and yeah, having that flexibility because people are varied. So that's me for today. There's some of my contact info. You guys can grab some of this stuff afterwards as well. If you ever want to reach out, I'd be happy to hear from you.